Today we're doing something a little bit different. Often we're reporting on new data or on new discoveries, but we also thought you might be interested in hearing about some of the studies that are currently underway and actively recruiting participants in. And happy that we have three of our research team members here today to walk you through the work that they do and see if you might know of families who might be interested. So I'm going to do some introductions. So our first is Ruvarashe or Ruva and Machivenyika. So Ruva is a research assistant currently working on the project called Caries Resistance Mechanisms in High-Risk Indigenous Children in our lab. And that is funded by the National Institutes of Health in the US, and we're working with partners at ADA Foresight Institute in Boston who lead that work. Ruva graduated from the University of Winnipeg with her Bachelor of Science in Biochemistry and a minor in statistics with a background in microbiology. And originally from Zimbabwe, she's been living in Winnipeg for the past 5 years. So she is one of us. She's a Manitoban, a Winnipegger. And during her spare time, she enjoys reading and hanging out with her friends. And sometimes you might catch her at RW and Company at Polo Park on the weekend. Next, we have Dr. Giselle Cavalcante de Oliveira Pessoa, or Giselle Pessoa. She's an internationally trained dentist from Brazil and also a research assistant in our program here looking at early childhood oral health research. She received her dental degree at the University of Fortaleza in Brazil in 2004, and her master's in public health at the Estadual University of Ceará, Brazil in 2011. So welcome, Dr. Giselle. And last but not least, Dr. Avinash Sarcar. Avi is also a research assistant in our lab, and his project is working on improving early childhood oral health in Indigenous communities. And after Avi completed dental school in India, he obtained his Master's of Science from McGill University with Anna Veli as his supervisor and folks there. And he was focusing his research on TMJ and sleep disorders. He's passionate about translational research, and when he's not working, he's busy thinking about what seafood to eat and cook. And he also enjoys some botany as well. He likes plants. So I am going to turn it over to the three of them. This is meant, we can hold questions to the end, but if something is burning, feel free, type it in the chat box, and we will try to monitor that. So I will turn it over to Avi, Giselle, and Ruva. Thank you.
Great. Thank you, Dr. Bob, for the introduction, and thank you everyone for coming to our presentation titled Tiny Teeth, Big Impact, Help Us Reach Young Smiles.
Guys, you're muted.
Ruva, we can't hear you. Sorry, you're muted. Sorry.
Okay. Start from the beginning.
Right. Can you hear me now? Yeah. Thank you, Dr. Bob, for the introduction, and thank you everyone for coming to our presentation, Tiny Teeth, Big Impact, Help Us Reach Young Smiles. And before we begin, we would like to acknowledge that we are gathered on Treaty 1 territory, the homeland of the Red River Métis, the ancestral lands of the Anishinaabe, the Anishinaabe, Dakota Oyate, Denisulin, and the Ininewak nations, and that northern Manitoba land includes ancestral lands to the Inuit. We acknowledge the harms and mistakes of the past, and we're dedicated to listening and respecting traditional teachings regarding oral health. Our research team and Healthy Smile Happy Child initiative are committed to building relationships with First Nations, Métis, and Inuit communities. to incorporate Indigenous knowledge in our research and health promotion efforts. By addressing the oral health disparities faced by Indigenous children, we strive to continue advocating for the oral health of all Indigenous children, their families, and their communities, fostering trust through transparency and respect. Thank you.
So good afternoon, all. Thank you for joining the presentation. Now, I wanted to start off by giving a small background about early childhood caries, because there's a whole new group that's attending the presentation. I thought it would be a good idea. So early childhood caries, here referred to as ECC, also known by other names like nursing bottle caries or baby bottle tooth syndrome, is the term given for tooth decay in children under the age of 6 years. Now, it is quite interesting to know that this is one of the most common chronic disease seen in children worldwide. Previous studies that have been carried out have shown that it is highly prevalent among the young population, and especially among the rural and the remote regions. And also to add on to that, it also is quite prevalent among the indigenous population, especially the ones in Manitoba. So we have a small chart in the slide, which shows you the prevalence of ECC in and around the region of Winnipeg, as well as other remote regions in Manitoba. And to add on to that, ECC just does not appear as cavitated lesions. It could also show as white spot lesions or even brown color lesions in the teeth. Next. So there are several factors which contributes to dental caries in children. And to start off with it, the primary factors would be the diet that we take. That is, if the child, or be it the adult too, if they take high intake of sugary diets and high acidic content, that would have an impact on the teeth. Adding on to this are the different microbes that are present in our mouth. Like some have some of the microorganisms would help in preventing, but there is a whole lot of new species that's found in research that is found to cause tooth decay. And to add on to this, again, you have the pollution component to it. So we would think, how would pollution cause something like dental caries? So indirectly, what it does, it changes the concentration of the saliva. It could also impact on the mineral content of the tooth, decreasing its strength. So in this way, it has an impact on tooth decay. And just to counter that, two of the easy ways to prevent tooth decay would be to have good and routine dental hygiene practices and care, and the most important, have a very healthy diet. So these two factors would help in improving the mineral content and also help in reducing the acidity of the saliva. As my previous slide already said, that there are several factors that are primarily responsible for the development of caries. On a broader spectrum, if you see, there are several other factors too, like the child level influences, the family level influences, the community level influences, which also play a major role in the development or the progression of caries in children. If you see, one important factor at the child level would be the oral health habits or behaviors of the children. And at family level, it would include factors like the socioeconomic status, while at community level, you would see the availability of the current oral health care system and the characteristics of the practices that's been present in the community. To add on to this, there are two important factors that also cause in the progression of tooth decay. One is time. It's just sorry about that. So it's two important factors. That's time and the environment, which have a major role to play in the progression of caries. Caries just does not happen overnight. It's a process which involves a lot of time. So it starts from, as I spoke to you on the previous slide, it just starts as an incipient white spot lesion where it be preventable, and then tends to progress into a serious cavitated lesion forms. So untreated ECC can have a major impact on the growth as well as the general health of the children. And previous studies that has been done in our lab that by Dr. Schroth shows that about 1/3 of the day surgery cases that happens in Manitoba is mainly related to oral health and early childhood caries. So from all this, what we know about ECC is that it is preventable. The other factor is that microorganisms have a major role to play in the progression and development of ECC. And a lot of awareness is required among the community and the population on early childhood oral health as well as prevention strategies for ECC. With this background, we develop or we have the following projects in Dr. Schroth's lab, and then would like Giselle to continue.
Sure. Hi, everyone. This is one of our research poster. We have all the study names here and some questions to the participant if they have child under 6 years old, if they identify as First Nation or Métis, and we are saying that a gift card can be given to them after the enrollment. And we have some information here regarding what we have. It's a free dental checkup screening, dental saliva plaque samples were collected, and parents will be asked to fill out like a survey or a questionnaire. We have information, contact information, and also participant can scan the QR code. They can fill out a Google form with the information, and we can contact them from here, from the lab. And we have at the end of the poster our partners. We're gonna talk about this during the presentation. So the first study is understanding the oral microbiome and mycobiome in First Nation and Métis. And as I said, we are funded. We have some partners, and we are funded from Canadian Institute of Health Research, CIHR, and we have partners, University of Manitoba. We have the Children's Hospital Research Institute of Manitoba, CRIM, and we have First Nation Health and Social Secretariat of Manitoba and Manitoba Métis Federation, MMF. We start with this slide because we do like to address the wonderful presentation that we have last year on the Healthy Smile, Happy Child series with Dr. Wasif Khan and Dr. Prashant Chalakani. They were presenting about taste genetics, ECC, and the socioeconomic factors involved in ECC. And so we are building upon this presentation, mainly focus on oral microbiome aspects. Who we are. As I said, we have FNHSSM participant as principal investigators. Principal investigator Elizabeth DeCare. We have Alina Claus from the MMF, Manitoba Métis Federation, as principal investigator too. And then we have us from the University of Manitoba, Dr. Juliani Sangis, principal investigator. And we have a First Nation principal investigator, Rhonda Campbell, from the University of Manitoba as well. And we have Dr. Kathy Yerkes, a Métis principal investigator. And as I said, we have Dr. Prashant Chalakani, Dr. Robert Schroth, my study coordinator, Betty Ann Miller, and myself, Giselle Pessoa, as a research assistant. So we have our background. We are, as I said, we are funded from CIHR, and we are focused on ECC. And we have significant health concern among First Nation and Métis children specifically, and which factors are contributing to ECC on these populations, like limited access to oral health care, poverty or food insecurity, lack of clean water, some loss of traditional diets. So we believe these factors, social environment factors, may contribute to like a more active oral microbiome. Then going deep on the study, we have a hypothesis where First Nation and Métis children with ECC have higher levels of active microbial strains that increase their risk for cavities. And then we have our objectives. Would you like to characterize the supragingival plaque, microbiome, and mycobiome, so bacteria and fungi. And we would like to compare microbial communities in children with ECC versus caries-free children, and analyze the molecular and physiological characteristics of carcinogenic microbes. So our methods is regarding the microbiome sequencing to identify bacterial and fungal strains, and molecular analysis of carcinogenic versus commensal microbes. So exploring a little bit more about microbial, so bacteria and fungi communication, we do like to study how bacteria and fungi communicate to form biofilms in the mouth, so and can contribute to ECC. Another thing is deleting key microbial communication genes in Streptococcus mutans to see how it affects the interaction with one type of Candida. It's the Candida dubliniensis, and also testing fungal signaling molecules to see how they impact the biofilm formation and the acid production. And one more thing we do like to compare with Candida albicans and maybe provide further insights. These finds, we believe, could help identify new ways to prevent ECC in high-risk populations. And continue with the methods, we ask to the community to sign the consent form, again, with children under 6 years old, that's under 7 months of age, and they identify themselves as First Nation and Métis. We do oral health assessment or dental screening, and we can do at the same day a questionnaire in person, or we can do over the phone, whatever is better to the participant, where we ask about general health, dental health, nutrition factors. So it's a big questionnaire that we can address to the parents and caregivers. We do sample of dental plaque and saliva. All the information in the questionnaire will go to REDCap, is stored there on the Research Electronic Data Capture. And just to remind, we have a partnership between University of Manitoba, Manitoba Métis Federation, and the First Nation Health Social Secretariat of Manitoba. We compensate the families with a gift cards that we provide after the saliva and plaque collection, the dental screening, and the questionnaire completed. We provide as well oral care products with free dental screening. And if the participant lives in Winnipeg, we can also offer taxi fares. So we have our timeline. We started being approved in 2023 by ethics. And then we start to engage with the community, and we open the dialogue regarding the project, and our team usually do some visits in the community to present what we are studying, and we present that we are doing questionnaire, collect samples, and during the visit, we usually do questionnaires and collect the saliva, and we do the screening, the checkup in the child too. And the analysis, and then the analysis of data from oral microbes, we're going to do as well. We believe we have some potential enhancements through this project. We believe we will improve access to care and free dental screening for children who participate. We provide oral hygiene supplies for families. Also, we provide a risk assessment for the tooth decay and evaluation of the dental service needs. We are uncovering knowledge on what makes the children more resistant or more vulnerable to tooth decay. We believe we are doing exchange of knowledge through regular sharing what we learn, and we would like to as well to find ways to help all children's teeth to resist to tooth decay. We have a previous study from Dr. Khan, Wasif Khan, and where he studied about the microbiome in 554 non-indigenous children in Manitoba, and it was identified that Candida dubliniensis as an important carriogen fungi. And then we have ongoing studies where we study specific genes in carriogenic Streptococcus mutans influenced by the activity of the biofilm in some cultures of Streptococcus mutans and Candida species. So the next step is going to be the microbial sequencing and bacteria and fungi. We have a table of our target. We would like to reach 500 participants, half of that, 250 First Nation and 250 Métis, with 125 ECC from the First Nation, 125 carries 3 from the First Nation. Same thing for Métis, 125 ECC, and 125 carries 3 from Métis as well. And today we have 192 participants enrolled, so we still have a way to walk. And First Nation 143, from those 95 ECC, 48 carries 3. We have 49 Métis with 90 ECC and 30 carries 3. We have participants from Winnipeg, the mainly sites from Winnipeg. It's the Misericordia Health Center, the CRIM here, Children's Research Institute of Manitoba. And we have other sites too in Winnipeg, like some Aboriginal health starts, some clinics that we can recruit some participants. And we have outside Winnipeg in rural urban community and rural non-urban communities. We have some pictures of us outside. So we believe we can have some potential impacts in this study. The findings could inform culturally appropriate preventive strategies and potential for targeted interventions to reduce ECC prevalence. Some future directions that expanding the research to include interventions and treatment strategies, and collaboration with more Indigenous communities to promote oral health equity. But we have challenges as well. We have difficult to recruit carries-free participants for comparison. And we realize that building reciprocal relationship with First Nation and Métis communities takes time. So it's normal, takes time. It's still a challenge, but we are making sure that when we are visiting a community and when we are in a site, make sure that we are not just entering these communities just to collect data and never come back, but also to come back and give some meaningful ways that we can foster trust, collaboration, long-term partnerships. Here it's our contact information. If you have any questions, if you know someone that would like to participate, if you'd like to enroll your place that you work, just contact us, send email or call us. And yeah, if you have any questions, okay, we'll go to the next one.
Thank you, Giselle. And I'm now going to be presenting on the next research project we have, which is caries resistance mechanisms in high-risk Indigenous children. This is a study we're currently conducting at Dr. Robert Schroth's lab in collaboration with ADA Foresight in Boston, and it is funded by the National Institutes of Health, right? And the central hypothesis for this study is that microbially reduced acidogenicity. We're trying to find that microbially reduced acidogenicity of Streptococcus mutans, and then the second key driver is enamel and dentin properties. Yeah. Composition of. Sorry, I forgot to mention. So these are the teams that are participating in this study. We have the University of Manitoba on the left. The project leader is Dr. Robert Schroth, and then the study coordinator is Betty Ann Muller, and I'm Ruvarashe, the research assistant. And then we also have Daniela Demaray, who is the community facilitator. We also have on the right the team from ADA Foresight Institute that is in Somerville, Massachusetts. We have Dr. Felicitas Biblack, who is a project leader as well as expert in tooth research. We have Dr. Jacqueline Starr, who is project leader and an epidemiologist. And we have Dr. Wiyan Shi, who is also a project leader and microbiologist, as well as Dr. Jusong He, researcher and microbiologist. Right. And we have two primary objectives in our study. That is to better understand the oral microbiome in children with caries-free and ECC in high-risk populations by analyzing those with high Streptococcus mutans loads and identifying microbial species that may offer caries protection. Our secondary objectives include to evaluate properties of teeth and test differences in tooth enamel or dentin properties based on the presence or absence of early childhood caries. We also would like to evaluate potential pathogenic mechanisms involving Streptococcus mutans and Rothia species and or enamel characteristics. What this means is that we're trying to identify the acid-producing bacteria and how tooth composition, properties of tooth structure such as enamel and dentin all play roles in caries prevention or developing of early childhood caries. And here on the screen, we have our recruitment process. We are recruiting participants in different First Nations and Métis communities across Manitoba. Participants are firstly screened for eligibility, and we do have an inclusion and exclusion criteria. The inclusion criteria is that the children must be less than 72 months of age, and parents and caregivers identify the child as either First Nations or Métis. Our exclusion criteria includes severe medical conditions such as having a feeding tube or having amylogenesis imperfecta or hypophosphatasia, and if a child has used antibiotics in the last 2 weeks. We use these as exclusion criteria because they may impact the composition of the oral microbiome that we're trying to study. After the eligibility screening, we do obtain informed consent from the legal main caregiver. The participant is enrolled into the study and we collect data. This data that we collect includes saliva and dental plaque, and also caregivers are given a questionnaire to complete about the child's overall health, diet, and developmental milestones. In this study, we also have the option, caregivers also have the option of donating naturally exfoliated teeth or surgically extracted teeth. The teeth can be returned to the participants once the study is completed. We also have the second portion of the study where we ship the samples we have collected to ADA Foresight for analysis. Data analysis will include microbiome profiling to identify acid-producing bacteria, as well as enamel and dentin mineral density, and looking for biochemical markers on the teeth that we receive. And so these are the type of information that we are asking for from the community. For dental health information, we're asking about diet, nursing or bottle feeding, and as well as the care of teeth or like the the oral health practices that are being practiced at home. And then also at what age the participants started getting their teeth. And we do collect specimens. So we collect saliva or spit, and then we also collect dental plaque from the tooth surface. And so here on this slide, we have a target number of participants. For our study, we hope to recruit 240 participants. And then we do have two cohorts. The First Nations, we hope to recruit 120. And then from the Métis cohort, we also hope to recruit 120 participants. And then we also then break it down to 20 caries-free, 100 with ECC on both of the cohorts. And as of today, our preliminary results are that we have recruited 145 participants, 105 of them being First Nations and 40 of them being Métis. And we have 35 in the First Nations cohort that are caries-free and 70 with early childhood caries. And then on the Métis side, we have 19 that are caries free and 20 that have early childhood caries. This is about, so all in all, we have recruited about 60% of the participants, but we hope to recruit more. And also here we've broken down our recruitment numbers based on the communities that we've been to. Our biggest recruiting site would be Winnipeg and the surrounding areas, but we also go to rural urban sites, and then we also go to rural non-urban sites to partner and recruit participants from there as well. And this slide is about how the families are compensated. So we do give families a $40 gift card once saliva and plaque samples have been collected and the questionnaire has been completed. So this is a $40 gift card for each child that participates in the study. And then we also provide free dental screenings, oral care products, and taxi fares for urban and community study participants, those who live in Winnipeg. And for this study specifically, if parents or caregivers decide to donate any naturally exfoliated or surgically extracted teeth, they get a one-time $50 gift card for their tooth donation. And as I mentioned previously, those teeth can be returned to the participants' families if they want them to be returned. And the potential enhancements through this project include improving access to care and free dental screenings for children who participate, providing oral hygiene supplies for families, as well as providing risk assessment for tooth decay and evaluation of dental service needs. We hope to uncover knowledge on what makes more children more resistant or more vulnerable to tooth decay, as well as to exchange knowledge through regular sharing of what we learn, ultimately finding ways to help children resist tooth decay. And so this is our study timeline. We started the project in 2023. We received ethics in 2024 and began recruitment. And then in 2025, we were recruiting, and we had the Boston team come to visit Manitoba. And then in 2026, we hope to continue recruitment as well as engage with the community as well. And this is the contact information for all the three studies. The research coordinator is Betty Ann Niedermüller, and I'm the research assistant. And you can email us or call this number for more information. Thank you.
Thank you all both for those talks. Now, the third project that we have in our lab is working together to implement novel culturally informed early childhood oral health interventions for young First Nations and Métis children in Manitoba. Now, this study or project was developed to address the oral health disparity of early childhood caries experienced by the children in the Indigenous community all across Manitoba. We have various partnering organizations with us, which includes the Indigenous group of organizations. We have the health organizations like the WRHA, be it the CIHR, which is a research organization, and also the University of Manitoba. This study adheres to all the principles of the ownership OCAS as well as the OCAP, that's ownership, control, stewardship, OCAS, ownership, control, access, and stewardship. That's what OCAS and OCAP stands for, as well as it also has received an approval from the University of Manitoba Health Research Ethics Board. Prior to going into the project, I just wanted to give you a brief idea about the Healthy Smile Happy Child initiative, because this project is closely associated with what they do. So the Healthy Smile Happy Child initiative is a community outreach program that was started way back in 2000, and it is a strong multidisciplinary partnership project that was developed to create awareness about early childhood oral health, as well as form preventative strategies for early childhood caries. The various partner organizations that are still a part of the Healthy Smile Happy Child include the the regional health authorities, the shared health. You have the University of Manitoba, you have First Nations and Inuit Health Board as well. Now the Healthy Smile Happy Child was built on 3 pillars. They are knowledge exchange, community engagement and development, and to add on to it is research, evaluation, and quality improvement. The major principles that's followed as a part of the initiative is to promote awareness in the community about early childhood oral health, and also to develop preventative strategies against ECC. It also looks into partnering with the existing programs to strengthen preventative strategies, and also to recruit and train natural leaders as well as staffs to deliver the preventative strategies. In addition to the 3, they also help in facilitating capacity building in the existing programs, and also help in assisting with the sustainability of the existing programs. Adding on to this, they also evaluate the impact of any novel research approach and inform the oral health strategies or developments that's happening across Manitoba. So these are the set of resources that is being shared with the community as part of Healthy Smile Happy Child. It could be in the form of flip charts, posters. It could be workshops that's being conducted. Could be in the form of games also. And we have a lot of resources in the form of videos that's been posted on the various social media like Facebook, Instagram, and YouTube, where you could access all our resources. You could also communicate with us with the email provided on the slide, or call to the following number, and we would be happy to share the resources with anybody. Now coming back to the project, so we have 2 major objectives for our Working Together projects. The first one would be to integrate traditional oral health teachings to improve the effectiveness of the Healthy Smile Happy Child initiative. Now this project is a community-based participatory research and follows a design called the serial cross-sectional quasi experimental design. I know it is a fancy term. It's just that it's something that when no randomization happens, it's going into community and learning from them, more of sharing and learning. So that's the design that we follow for the study. Now the purpose for this objective was to expand our Healthy Smile Happy Child initiative to other communities, and also to access the accessibility and feasibility of our initiative, along with the effectiveness of Healthy Smile Happy Child. We also wanted to assess the changes in the attitude, the knowledge, and practices of parents or caregivers towards early childhood oral health as well as ECC. We also wanted to understand whether the Healthy Smile Happy Child initiative helped in causing any changes in the oral health status of the children, and also to look into what elements of Healthy Smile Happy Child model work well with the specific communities. The project also aimed at understanding what the barriers were, what the implementation challenges and the facilitators for the project were. So to address the objective, we followed a design which included a quantitative as well as a qualitative part. Now, the qualitative has mostly to do with the numbers, that's the scores and all the stuff, while the qualitative part deals with interacting with the community, understanding what their traditional teachings are, learning from them, and also sharing with them our resources in the form of maybe presentations, group committee meetings, and workshops. So the first part would be the quantitative part, where we recruit. So we aim to recruit about 40 to 75 parent-child dyads. That's so the parent and the child together would be considered as a single participant, and we aim in recruiting about 40 to 75 in each community. Once they get recruited, we do a baseline questionnaire with them. So the baseline questionnaire is with a parent, and it mainly contains information regarding the child's diet, the oral health habits of the child and the parent, as well as some questions regarding the dental visits and what are their approaches towards treatment or also their awareness. So the questionnaires are quite straightforward. Another component of the baseline is that we do an oral health screening, which takes into, so the screening would be done by qualified dentists. Sometimes they could be qualified dental hygienists too. And it would take into account about what the overall oral health status of the child is. It includes about information about the debris, the plaque, the calculus, the gingival health, whether there's any cavitation or not. And it also includes another component, whether any immediate treatments is required or just preventative strategies would be fine for the child. So once the oral health screening is done, we would also take consent from the parent whether we could do varnish application to the child. And we do it only if that's the fluoride varnish. We do it only if the parent consents and they're okay with it. So once the baseline is done, we tend to do some amount of analysis in understanding, okay, what are the disparities there? What needs to be addressed? And we get back to the community and we tell them, okay, these are the things that we found out, share with them, get their feedback. So it's always an ongoing active participation between the research team as well as the community. And once 42 months is passed, so within this span of 42 months, we tend to go back to the community very often, share our resources, conduct maybe camps, presentations, workshops, just to teach them what we know and also understand what they could teach us. Now, following that, we do a follow-up visit at the end of the study. Could be over 42 months. We need not follow the same participants. That's why I mentioned that it's a quasi-experimental model. So the same participant need not be followed. It's the community as a whole that we follow. We do the same set of questionnaires and also do an oral health checkup to understand what the status of the community is post the Healthy Smile Happy Child implementation. Coming back to the qualitative part, this is where the whole point of knowledge exchange and community engagement happens. So it's more of sharing circles and focus groups with the parents and understanding what they do or what they intend to do and what we could provide them with. In this case, we tend to recruit about 100 participants for the study. And right now, the current status of where we stay is that about 206 participants have been recruited for our quantitative section, and about 22 participants have been recruited for our group discussions and focus groups. The various communities where we visited includes urban setups in and around Winnipeg, and also some of the rural areas like Brandon, Broken Head, Portage, St. Lawrence, Selkirk. So these are the sites where we visited, and we also do some amount of screening at the Children's Hospital Research Institute of Manitoba. I'm not going to go deep into the objective to it as it is beyond the scope of our presentation. So it is mainly to do with implementation of caries risk assessment that was developed by Dr. Schroth and his team in early childhood by non-dental primary care providers as a mean to improve access to oral health care. The main purpose of the study is to identify non-dental primary care providers and understand what their barriers, training needs, and facilitators would be. We also train non-dental primary care providers and determine their acceptability as a part of this project. In addition to this, we also concentrate on developing guidelines for training, implementation, and integration of caries risk assessment tool among the non-dental primary healthcare providers. This would facilitate in preventing as well as reducing the burden of ECC on children under the age of 6 years. Now, what we anticipate by our study is that it would be nice if we could see a reduction in the prevalence of ECC and improved oral health quality of life for the children. We also would define with it would be also good to know that if there is any improved community knowledge, attitudes and behaviors that we could compare prior to Healthy Smile Happy Child and after Healthy Smile Happy Child. And it also helps us in identification and most importantly resolving the barriers that was found during the implementation of the Healthy Smile Happy Child initiative. So as again, to reiterate, it is always a two-sided talk here, because it's just not us going into the community. We also go back to the community and share our research findings with them. Now, the whole team is involved in this project. It's just that my picture is there and Daniela's picture is there, but it's just not us. There's Darianne who helps us. There's Mehak. There's Adrian, Rua, Giselle. All of us are involved in this research. And you could contact us if you have any further questions. I would like to end my part here, and then it would be taken forward by Dr. Schroth. Thank you.
Just to put a plug about another study that we're currently funded for by the Canadian Institutes of Health Research. And so we are currently interviewing families of children under 18 years of age to find out their awareness of the CDCP, as well as their experience that they have in applying for and using the CDCP. Particularly, we are interested in connecting with Indigenous families who potentially have not had much or have not received much information on CDCP, and there is a gift card. So again, if you are interested in that, I don't think we have the QR code big enough on the screen to do that, but please reach out to us. And Avi, I'll turn it back to the three of you. I don't know if you have some summary slides to just remind people. I think our big ask is if clinicians on this call would be willing to promote this study in their offices to families that they see. But go ahead, please. Just for time, make it just because we want to leave time for questions. If you could quickly do that now.
Yeah. So that's
Awesome.
Yeah,
so
so
that's
again, so we have these posters available to distribute. So if your offices would be willing to put them up, please let us know.
I think what's important too is that the beauty of all of these research projects is you don't have to choose one.
Yeah.
If you meet all the criteria, we can have you do the different studies all at once. And the questionnaires are very similar. So we really are doing almost one questionnaire for all the studies. And then what is the total amount of gift cards they would get if they participated in all the studies?
130.
So thank you, Ruva. Thank you, Giselle. Thank you, Avi. And we'll open it up to questions. And Daniela, you probably have some, you've probably received some already in your chat box.
Yeah.
So yeah, go ahead. Thank
I'll
you.
wait for other questions, but just as I'm waiting, I do have one here. How long are these study visits, and would families get assistance with transportation? I think we mentioned that.
Yeah.
How much money would they get for each child? So we did mention that as well, but how long are the study visits? How long does it take?
You're muted. Yeah.
Thank you for the question. You can hear me?
Yes.
Yes. So we do have the screening and the sample collection part. That's usually maybe 30 to 45 minutes. And then depending on how many participants are being recruited from a family, we also have the questionnaire. Usually it would take about 45 minutes to an hour. But that questionnaire can be done over the phone before they come for screening and the oral to collect the samples. So all in all, it would be like maybe I would say a 2-hour process.
Okay.
And do they have to
Sometimes
come
done
during your,
faster.
oh, sorry.
Okay.
Do they have to come during your work hours or?
It depends.
No.
We can arrange. It doesn't have to meet our work hours. Yeah.
We can do after hours.
Yeah.
Right.
Yeah.
The questionnaires can be done after hours based on their convenience. We could do it through phone call or video call.
Same with the
This-
screenings,
Yeah.
if
Yes.
there's advance notice.
And so the best way for them to connect if they're interested in the studies would be the information that's on the poster here, right?
Yes. Yes.
So they could scan the QR code there, and it directly takes them to a form where they could register. All that they need to do is in the form they need to give the name, the phone number, as well as their email address, and we'll get back to them.
Or call or email as well. There's information there. But how do we get these posters in the hands of people? Like, would we mail it out, or do we want to email it to people and they print it and put it up in their waiting rooms? What are our options? Can we send copies to offices if they request?
We can send by email, right?
So we have different strategies within Winnipeg. We've been visiting the daycares and the Head Starts. We go in person, and we could distribute the posters. And in addition to that, we also send emails to the coordinators.
So I personally would like to see a copy in each of the operatories in the clinics that I work at. That would be very nice to have.
Yeah.
But I think maybe there's other hygienists and dentists and assistants on the call who might be willing if they got some. So yeah, and Betty Ann's written, if a private clinic wants a poster, just we can print and mail them posters to put up.
Right.
Yeah, you can mail them.
Yes.
So.
Thank you. And I guess Tiago had a question. If
I
everybody...
have a question here,
Oh, sorry,
actually.
Danielle.
Do the posters need to be posted in dental offices, or can they go through small communities like our local stores? I know community centers even would be ideal.
Yeah, I think we'd say anywhere that
Anywhere.
people are allowed to post things for public. Absolutely, Pauline. I think that's fabulous. Thank you. Just maybe reach out to Daniela or Betty Ann and we can put some in the mail for you. We're going to St. Laurent and Selkirk to do screenings at the Head Starts in the coming weeks. So we will bring some along as well to post. Yeah.
April 21st will be in St. Laurent, and the 27th we will be in Selkirk.
And Daniela, these posters have been shared on our social media handles, right? So
yes,
what are our Instagram and Facebook? How do people find us there?
Healthy Smile, Happy Child. You'll find us.
Perfect. Thank you.
Don't see any other questions.
Yeah, I see one. Can the same child participate in more than one study? And I think yes, right? We're doing that routinely, trying to combine different studies into one visit. And that's, I think, why the study visits tend to be a little bit longer than an hour if we're doing collection for more than one study. Great.
So I guess we'll wrap up, but I thank you everybody for participating. And if you have any ideas of where we can promote, please reach out to us. Our next presentation in the Healthy Smile, Happy Child presentation series will be on May 12th at 12 p.m. CST. It's entitled Utilization of Silver Diamine Fluoride by Dentists and First Nation and Métis Patients in Canada, a review of non-insured health benefits dental claims database. And it'll be presented by Dr. Robert Schroth and by Mohammed Abdullah, but we'll send out more information shortly.
Thank you, everybody.
Thanks, everyone.